It was almost too easy. That look in your eye that said that I was almost home.
Hello, everybody. Welcome to another pop-up journal club. Thank you all for taking the time to join us. We are joined today by Dr. Courtney. Say hello, Courtney.
Hi.
Courtney is the mad scientist in the right in this photo. We were supposed to have Dr. Cindy with us as well. She has had an emergency on her farm, so she's going to be giving, I almost said giving birth. She's not giving birth. She'll be delivering an animal. So we are representing her in spirit with this nice photo of a cow you see on your screens right now. And hopefully she'll be here in spirit. Courtney, why don't you, while I download the newest slides, because Courtney spent all this time making slides for you all today, I'm going to download those and get them up for you. While I'm doing that, Courtney, why don't you tell us what you got planned for the weekend?
Honestly, no plans. Life is fairly boring in a COVID cautious sense, correct? If at all possible, I will be joining a friend group of mine at their farm, where distance and masks are used with bonfires and drinks of your choosing. I do not typically take my mask off for that unless I'm quite far away, but weather permitting. Weather is too crazy here to ever really know what's happening. So the backup plan, if I do not get to go visit them, will be to continue house renos. That's the sinkhole for my spare time. Renovating a house solo. It's a good time.
Yes. Luckily, I don't own a home, so I don't have to do any renos. All I have to do is tidy up the apartment every once in a while and hope the landlord thinks it's a good investment and doesn't charge me more rent.
They can always charge you more, sometimes without reason.
Yes, my building's owned by a private equity firm, actually. So
Huh.
who knows? Traditionally that's a really bad landlord to have. For those who don't know, because they only care about returns to their shareholders, and it's one of the reasons why renting has been so unaffordable in the United States and Canada over the last 5 years. A huge increase in the amount of properties owned by private equity firms. Supposedly, the one I have is like not terrible because they're very new to real estate. And so, or at least residential real estate. So they don't really have like a system in play yet to maximize their profits. So my rent is reasonable.
That's always good. Buying is buying is a different topic. We could go on that for a few hours, but we'll spare the viewers of that.
I think that's wise. I have the slides up now, so you all should be able to see them. If you can see the slides, feel free to type something into the chat so we know the slides are up and you can see them. I am just going to jump over to Twitter quickly and let everybody know that we are live. All right, close that.
While we're waiting, Wes, it's your turn. What are your plans for the weekend?
Mostly work. I got a lot of work to catch up on. I'm presenting at not next week, but the week after. I'm presenting at a conference in Scotland, and I have two presentations. I'm on the docket twice, and I gotta finish some of those PowerPoints and get some of that analysis, last minute analysis in on those things. And unfortunately, there isn't time during my normal day job when I have to be doing all my other tumor analysis work to actually do the work I need to do other work. It's the fun life and cancer research we live. Always work. Right, I'm just gonna copy this. Thankfully, I wrote a description at least for what we were talking about today. And we should be good to rock and or roll. All right, that was working. That's working. Copy. Paste. Perfect. All right. I have posted my version. Hopefully somebody might see it. All right. So shall we jump right in then? Should we start with you, Courtney? Should I progress the slides? The slide number 1 for you?
Sure, we're going to test this out. First time on YouTube Live, so we'll see how this works.
See how it works. And oh, by the way, for anyone who got a notification and who are joining us right now because you are subscribed to the Tumor Talk channel, this will not be the permanent home of these journal clubs. These journal clubs are a little bit more high science than some of the other content on this channel. It's just the pop-up journal club didn't have a home temporarily, so we are just inviting them into ours for a short period of time for tonight, and then they're going to get their own channel as they find out where they want to be. They're not sure if they're going to be on Twitter or Facebook Live or YouTube Live. They'll figure that out on their own. I'm just hosting them tonight.
Thank you for letting us sublet.
Yeah, and I didn't even charge you as much as rent. All right. Slide 1 is up for the overview. Take it away, Courtney.
Well, there is a small lag, so I will start reading from my side and hope that it catches up.
So the lag, for those you can do it. Just so you know, you can do that. So there's a delay in the feed, but you speaking is also with that delay. So
perfect.
Assume what's up.
So for those of you who have been following the Pop-Up Journal Club since the beginning, we are trying a slightly different format today. So that will consist of an overview, and we're going to do section by section summaries, which include backgrounds, methods, results, and discussion, rather than narrating the paper with you. So if you have not opened the paper, it can be found on the Twitter page for Pop-Up Journal Club, as well as any of the reposted links. So you'll be able to find that and follow along if you choose in that way. Otherwise, the slides will be hosted whenever we find our permanent home, and you'll be able to resort back to those as a reference if need be. And then at the end, we will conclude with, what does this paper mean? How does this work in real life? And if there are any audience questions, be from the chat, or if you're able to DM one of us in Twitter, we will try to moderate that as well. Given that we are down a member, it might have a slight delay. But that being said, do not hesitate to ask us questions. We will try to answer that as quickly as we can.
Perfect. Yeah, let's give it a go. We're in the frontier here, trying something new. Slide 2, background.
So with the background, we all know at this point that SARS-CoV-2 RNA has been detected in the nasopharynx as well as the gastrointestinal tract beyond acute symptoms. So that does imply that there may be viral persistence occurring. So they did say that recent findings did indicate that there is a prolonged presence of SARS-CoV-2 RNA or protein in various sites, which further suggest that the viral persistence does occur in the form of reservoirs. But the implications of said reservoir are not necessarily known, but even in a small percentage of individuals could have a significant population level impact.
Yeah, and so one of the things we don't know, from these studies, so we know viral persistence is a thing. That part has been kind of demonstrated in other studies, autopsy studies, different organs, different parts of the body. Part of it that's not entirely clear is how long the viral persistence lasts. A lot of these patients were either, and unfortunately, in autopsy, so they had to die first to test all their organs. It wouldn't be very ethical to start harvesting living people's brains looking for this tissue, these virus samples. And so we don't actually have a great medical background on when their last infection was. We know for most of them, for some of the studies that look specifically at long COVID patients, we do have their initial infection, the infection time point when they develop long COVID afterwards. But for longer term, we don't know repeat infections, when their last one was. So that's why you'll see a lot in the writing and literature, maybe up to a year, it could be viral persistence, but we don't know when the last real exposure is. And so hopefully, as we'll get into for this in discussion, something like this paper is proposing could even help us study that better.
Absolutely. And I'm sure by this point you might have seen, or maybe not, depends on how much downtime you had today. There was a post listed in Twitter that a man had positive COVID test for over 600 days before ultimately succumbing from that. So there are rare instances where it lasts much longer than we currently know.
Yeah. All right, moving on. Next slide.
So this study attempted to address a lack of definitive evidence. Most of the studies done up to this point do have small sample sizes, unclear vaccination and reinfection histories, which Wes kindly touched upon already. And there's also a lack of true negative comparator groups or controls, right? This has been ongoing for 5 years at this point, so it's hard to find a true control group. So they did take advantage of that. So they evaluated SARS-CoV-2 antigens in plasma over 14 months post-acute infection in a large, well-characterized group. So they were able to find enough controls from historical plasma banks, essentially, to use that. And those were the pre-2020 uninfected individuals. And then they also compared other host factors to assess what influence that might have on the persistent SARS-CoV-2 antigenema.
Yeah. So the second group. Did you want to talk about the second group of patients they used?
Sure, that's in the next slide of
Perfect.
participants, if you'd like.
I got it, Chet.
Thanks. So we'll break down both groups. So the pandemic era group consisted of participants from the UCSF-based LINK study. And then they also had consecutive adult volunteers with confirmed acute SARS-CoV-2 infections, and the enrollment period started from April 2020 onward. So these participants were at least 2 weeks removed from the onset of their symptoms and were recruited through facility and community-based advertising. So there was some word of mouth at play here. And then the examinations conducted at the initial visit were therefore conducted every 4 months thereafter. So they did do a fairly widespread of examinations. I would have liked to have seen maybe something sooner than every 4 months, but at least they're, starting somewhere consistently.
I can do the second group, the pre-pandemic era group. So these patients or participants, if you will, were from another study. They're from the SCOPE study that started way before the pandemic in 2001. These are all people who had HIV infections at a variety of time points. They didn't all get their HIV around the same time. It was a long cohort study. And so their samples, and this wasn't just everybody in the SCOPE study. They just randomly grabbed a whole bunch of samples from patients who were in this. They had stored plasma specimens, and they tried to match the best they could sort of the age, the race, and the ethnicity of the pandemic era group to this pre-pandemic group. Try to control for all those things, because all those things are going to matter for anything in the blood. If you're looking at any markers in the blood, age and race and gender are going to play a role, and they've tried to control for that the best they could. Methods.
Would you like to continue, or do you want me to pick it back up?
I can let you pick this one back up.
Perfect.
I'm going to jump more to you, because without Cindy's help doing the other stuff, I have to manage more of the tech stuff.
Understood. So they compared SARS-CoV-2 antigens in plasma using a technique called Simoa, which we'll break down briefly in the next slide. But they looked specifically at the post-acute phase of SARS-CoV-2 infection and then the control group, or the pre-pandemic. So that, again, other factors were discussed and evaluated. So they looked at sociodemographic characteristics that may have an implication on the antigen detection in the post-acute phase. So just keep that in mind as we're discussing this. So that could be anything about, economic status, or, what their job might be, their risk factors that we see in day-to-day lives.
So what is Simoa and how does it work?
So Simoa is a single molecular array, or SIMOA. And essentially, I'll give the brief one, but if Wes has more detail to add, by all means do so. It's an ultrasensitive ELISA, or enzyme-linked immunoabsorption assay. So essentially that will allow antibody-coated beads to be used specific to your antibody or protein of choice. So in this case, they're looking at the S1 spike protein, S2 protein, and the N or nucleocapsid protein of the SARS-CoV-2 virus. And then once they have that bound, that will be added to the serum from the plasma, washed and bound to a fluorescently conjugated dye, essentially, that the bead reacts to. And you'll wash away the excess so you know that it is bound specifically only to the proteins of interest. And then that type of reactivity is emitted as a fluorescent color and then read by, an assay machine of choosing, probably too expensive for most labs. But if you are able to get this, it is unique that it is a single molecule array. And it does not require as much sample and can detect very small amounts of the S1, S2, or N proteins in this case.
Yeah, so like a big thing with this technology, and it's used in immuno-oncology a lot too, so I'm familiar with it, is that it's supposed to be the sensitivity, right? So the company that makes this, markets it as 1,000 times more sensitive than conventional assays that are kind of similar, and it's part of this bead solution is how they're achieving this. The one thing to keep in mind, kind of going forward, when people are trying to make panels that are biomarker based, especially in the age of liquid biopsies, where we're taking patients' blood and trying to find markers for cancer presence, cancer prediction, any disease state in a liquid biopsy kind of format. Is you usually want a lot of data. Simoa is limited in how many markers you can look at a time. So I believe the default assay actually lets you look at 10 molecules at a time. But it's very sensitive to those 10, whereas some other technologies that you might screen the blood for to look for the presence of things, you might be able to look at 100 markers or 1,000 markers or 10,000 markers, but their sensitivity to detect small amounts is greatly reduced. And so that's kind of the trade-off here with Simoa versus traditional kind of detecting of some of these molecules.
Interesting. So I know that they did use those 3 proteins and they were processed separately. So during their micro well plates, it was 1 protein at a time for them.
Yeah, and like there's lots of ways to do this. There's there's the old school ELISAs. There's immuno PCR. There's a whole kinds of other approaches for protein detections. And Simoa is is a proprietary sort of new assay. All right, jumping ahead now to the results. I can read the first slide since it's very easy to read and requires no background knowledge that Dr. Courtney has. So in this thing, they had 171 pandemic era patients in this group. So again, these are people with had acute COVID. At least 2 weeks later, they're non-symptomatic, taken their blood, and or in this case serum, which is harvested from the blood samples. And then they had 250 pre-pandemic from the HIV study, which is an interesting control. Do we want to talk about this control right now? This could be a good spot to talk about it.
Yeah, we can.
So I like this control for one reason, and I dislike it for another. Obviously, one struggle with any COVID study, whether it's a SARS-2 acute studies or it's long COVID or anything like that. In this case, specifically looking at viral persistence, so something that's happened post-infection, is getting samples from people who aren't infected, who have never been infected, ever. That is really hard to do because of the amount of asymptomatic infections being a problem, as well as that in many districts in the United States and Canada, at some point, testing essentially stopped. Recommendations end up being like, if you have these like flu-like symptoms, let's just assume it's SARS-2 and stay home and don't get people sick, instead of having everyone constantly going in and getting PCR tests. And so there's people who may have never had a positive test who have definitely had SARS-2, and that's a hard thing to control for. So
right.
getting access to samples you have what we call biobanked, samples that are stored from another study, from other patients before SARS-2 emerged, so they couldn't possibly have ever been infected. That would be a good standard. That's a really good gold standard. The downside in this case is that these people, and good and bad, this is like not a bad thing, is that because they have an HIV infection, and because in California, which is considered, definitely a first world area, these patients will be on retroantiviral cocktails, so multiple retroantiviral drugs. It might, you could imagine trying to develop a signal, trying to find antiviral signal in the blood using a control with someone who that's going to be the complete opposite turned down. Are you also turning down other signals that might just be present in normal healthy controls?
Mm-hmm.
On the other side, it's like, oh, well, now we have a known persistent viral population. Like HIV is persistent viral, right? With the exception of a very few cases involving bone marrow transplants, people are not cured of HIV, although they can live with it their entire lives and not die from it. It's not a death sentence anymore. You could argue that this is a good background control, because now you're like, this is a specific assay now for SARS-2 and not just for any viral predictor. And I want to just end that caveat, looping those two things back into each other. You can imagine that, hey, that makes it a good control, because infections will have interferon and other inflammation markers, and we don't want to be just picking up any inflammation markers in our panel, because then how would you tell someone had long COVID and not just any other virus? But it brings me back to my previous thing, in that patients in California who are on retroantivirals may not have those markers up because their viral load is predominantly undetectable. Anyway, that's my insight on that, and my thoughts on that group. I think it's, if you can get pre-pandemic samples for a study like this, you have to do it. Great that they could. Only thoughts on that.
Sure, and I have some other ones based on the context of the group themselves, but I'll leave that for the discussion. I do think that might come up with audience members as well.
Okie dokie. So yeah, again, we talked about the similar ages. There was more women, Latino and white participants in the pandemic era. Both groups came from studies enriched for HIV, but 4 participants in the pandemic era group developed COVID-19 prior to SARS-CoV-2 vaccination and prior to the Omicron era. So that's an interesting point too, is that how do these mutations between the different variants of SARS-2 impact viral persistence, and how does the vaccines impact persistence? We do know, again, while not all long COVID is caused by viral persistence, one hypothesis is that some is. And we do know from other studies that if you were vaccinated before your first SARS-2 infection, you have a 33% chance, less chance of developing long COVID. So we already have those kind of correlations. So this is, it's a good thing to keep in mind when interpreting the results of the people in the study.
Absolutely.
We are on the measurements slide.
So just to give you some context, they looked at 2 different measurements, both questionnaire-based and laboratory-based. The questionnaire-based data included the sociodemographic and economic factors as discussed previously. And then specifically in the pandemic era group, they looked at the details around their acute phase of their infection, and then what symptoms they experienced during that first 3 weeks, and those were documented as well as possible. They also relied on self-reported data, so that would be a worst perception of overall health on a scale of 0 to 100. And then if hospitalization for COVID-19 occurred, that was noted as well. Any vaccinations acquired during this period were recorded, and any additional reinfections, if found, as Wes so kindly already mentioned, many of the infections are asymptomatic, so these individuals may not have known. And at that point, even if they are coming up negative on a PCR test, is it possible that they still have the N-capsid protein surrounded within their blood? So it is possible that reinfections were missed. And that is one limitation that the authors were quite aware of, and we will discuss in later slides as well.
Of course. So Paul says in the chat that early on that their testing may not have been as prevalent either. And so they are suggesting an end period of when tests could be reliable. Yeah, he's suggesting mid 2020 for his region, I'm guessing. He's also saying end of 2021 for his region. I know some areas went far into 2022, especially in some places in Canada. I'm Canadian, and Dr. Courtney's American. And definitely different areas in different states ended at certain times and started earlier. I know in Ontario, testing was very early 2020. I was sick and early. I had viral meningitis in March of 2020, and when I was in hospital for the ER, they tested me immediately for SARS. So, I mean, again, I guess the point is reliability, but it's also a good point to keep in mind that I was mentioned that after a point we stopped tracking it.
Yeah, and even now, I mean, tests are so hard to acquire. Many rural areas don't even offer PCR at this point. So if you find yourself in that situation, the last known resource that I have would be LabCorp. You can purchase a PCR test from them, and it's sent with a biohazard bag and the buffer solution and the Q-tip that we're all used to from at-home tests. But then that is shipped out in a prepaid envelope from them, and you get the results back much like you would through a pharmacy within 2 to 3 days.
Yeah, and the costs have kind of gone up as well. Well, so obviously, depending on where you live and what healthcare system you're in America, most health insurances, if you are one of the people lucky enough to have health insurance, they will cover the visit to the clinic to get the test. But the clinics are kind of upcharging the visits in those situations. And it can be $100 to get a PCR test, and that's not in.
Oh, it's not more. I think my insurance charges $140 per PCR.
As a copay?
Yeah.
Damn. Yeah. No. Here, it's depending on your thing, it'd be 20, depending on your insurance and your deductible and all that stuff, between $20 to $50 copay, and then the visits then covered. But then they could charge you an extra $100 if you get a PCR test instead of a rapid.
And I mean, we all know the rapids aren't as great as the PCR. So if you find yourself in that position, it's not fun.
No, the rapids are have some limitations. They get worse and worse with each mutational variant. Their the false negative rate is very high. The true positive rates are still pretty good. So if you get test positive on a rapid, you can be very confident that it is true and you have SARS. The downside is that if it shows negative, you can't know anything. My boss, actually made fun of some of the border groups that were accepting antigen tests as negative SARS to let people cross different borders. Different countries during the pandemic were limiting travel across borders depending on if you were tested positive or negative as a requirement. And since they essentially since the negatives don't mean anything, he would make fun of them for why even do them? Why even do them if the negatives can't be trusted?
Right. I mean, at that point, it becomes more of an offline argument, right? Like, just mask. Yeah. Be safe, just mask. Don't assume.
Yeah, you're not wrong. You're not wrong. How far do we get in the measurements? Did you finish the measurements before I went on a tangent?
Finished questionnaire-based. We can move to laboratory, which we've kind of already touched on, so it might be redundant. I apologize in advance.
Nice. Laboratory-based methodology.
So this is the quick and dirty summary of this, but they did have peripheral blood collected in the EDTA-coated tubes, and then they spun down, got the plasma, and then collected that, storing it at -80. So they have a disclaimer. Similar procedures were used in both the pre-pandemic and pandemic era groups, given that these were samples collected from 2 different studies spanning over, a 24 or 23-year period at this point. But they did use Simoa, as mentioned. The brand was the Quanterix Singular Molecule Array Detection Platform. And then again, the antigens measured were the spike S1 and S2, and then the nucleocapsid or N proteins. And all of those were performed separately.
SARS-CoV-2 antigen detection in pandemic era compared to pre-pandemic era. All right. So pre-pandemic positivity in at least one of the antigens was 2%. So that kind of gives the established assay, since we assume there is none of these NS1 capsid proteins in them. That's the assumption of the control. Lets us know what the false positive rate is. And Courtney has given us here the breakdown of what percentage of those particular antigens were, which implies that the N antigen had a less false positive rate than the spike and the S1. Positive examples of positive participants, various ages, ethnicity, to HIV seropositive. Oh, that's interesting. So they had to detect. Oh, wait. When you say seropositive, are you saying they had antibodies for HIV, or are you saying they had a detectable HIV level?
I do believe they had a detectable level.
Gotcha. Cool. Good to know. Yeah, that is. I wonder, have you looked at this in the supplemental or in the figure? Were those two patients part of the false positives?
Not in the supplemental. I have not looked there, but I don't know if they included that in the overall figure that we'll see in figure 1, or if they were removed as outliers. But I think this was essentially used just to establish that baseline.
All right. If we don't get that answer from the figure, that's a good thing for the discussion at the end when we're taking questions. I'll go look at that in the supplemental. In the pandemic era group, 61 out of 660 samples tested positive for at least one of the antigens. 42 unique participants, 25% of that group. Most commonly detected spike 5%, followed by S1 2% and N 2.3%. Most instances showed a detection of a single antigen, exceptions were rare. So from the way I read it, and maybe you are, maybe we've interpreted the results section a little differently, or maybe I've just read your dot points in a way and interpreted them wrong. So I read this as basically their detection from what what they're saying is that the majority of these samples didn't have S1, N, or spike at all, right? So is that's the interpretation we're doing here correctly?
Yes.
Okay. Yeah. So 25% having at least one marker, or 9% had at least one. Is that correct?
Yeah, one or more. Yep.
Okay. So this is an interesting number I want to come back to in the discussion, because I think it loops back in with some other previous published data that I want to come back to and loop in with that 9.2. They do put the concentrations for the detected antigens in there, basically showing that they're all below, roughly around 30 picograms per mil. Again, an advantage of Simoa detection, being able to detect small amounts of these proteins. Although you'd imagine some of these shouldn't be totally mutually exclusive. We have a question. We have a point from Paul, or a question. Paul asks or says, I wonder what aspect of the test produces this false, or if patient driven and they have something that matches which can't be SARS-CoV-2. Yeah, that's right. And he's just saying, he's just confirming what I was suggesting, but the very few had more than one match. Yeah, I mean, it's interesting. I think it's possible that maybe the seropositive patients are playing a little bit of a role. But also no test is 100% for false positives, right? Every test has a point where there's triggers in the assay where those beads are just binding or just randomly being pulled out from the wash, because there's a wash step, and if you don't wash away all the beads that don't bind, it's going to light up like it's a true signal. So there's sort of a technology detection, kind of how the physical mechanics of how this assay works, that could produce a false positive for these things, independent of if you were just using saline as a control. So I don't know where the false positive rate from the previous slide, what the source of that is, but it's pretty low. So I feel pretty confident about that.
Agreed. Then I think we will break this down, at least with the figure for those of us that are visual, and it might better answer some of the questions from the bullet points as well.
Yeah. So figure 1, prevalence of SARS-CoV-2 antigen positivity and plasma among participants in the post-acute phase of COVID-19 in comparison to pre-pandemic participants. All right, so A is any SARS-CoV-2 antigen. So we have the pre-pandemic group with, our baseline, which we are basically calling that our false positive rate. And then we have 3 to 6 months post-COVID, 6 to 10, 10 to 14. So over a year, and still detectable limits for any marker at all. With the S1 variant, S1 antigen, looking like has the earliest turnoff, I guess, and the highest, the peak expansion appears to be with the spike antigen, and the lower engraftment, it disappears to the lowest amount in the N antigen. That's how I'm interpreting this.
Agreed. And it does have some interesting implications I think you were part of that discussion, I'm not sure, with the PEM paper, when they found the viral fragments in muscle.
Yeah.
So that extended quite far too, and they were specifically looking at the S1 versus N, but based on their time period, it was beyond a year as well. So because it's decaying, between months 6 and 14, that might have been missed, but the damage that it caused in said muscle tissue might not be transient.
Yeah, I'll want to check a little bit on how they did the stats, but it's important to know that while there is positive signaling at 10 to 14 for all three individually, they're not statistically significant compared to the pre-pandemic group in any case. It's only as when you group them all, when you say, hey, any positive protein marker of these three, then it's statistically significant to pre-pandemic. But any one marker doesn't beat that false positive threshold for statistically significant for the 10 to 14 month time point.
Mm-hmm.
In fact, for the S1 antigen, none of the time points are statistically significant. I just noticed.
Yep, none of them are.
Interesting. I mean, I kind of know where they're going with this because I've already read the paper. So this kind of now that I see this bar chart fully and I've had time to appreciate it, I can see why they went in the direction they did with the spike antigen. All right, I'm going to switch to the next. Unless you have anything else you want to comment on this, Courtney, I'll switch to the next slide.
Nothing add to this figure.
Yeah, so it's all kind of good stuff to know, guys. If there's any questions about that, please put it in the chat, and we can always come back to this slide. Figure 2, quantitative measurement of SARS-CoV-2 spike, S1, and nucleocapsid antigens in plasma among all pandemic-era participants during post-acute phase of SARS-CoV-2 infection. I clearly named my figures in my papers too short.
Honestly, the brevity is appreciated. I don't understand why this is so lengthy.
Yeah, I haven't been using proper sentences for my titles for my figures, but maybe I should be, because these guys, well, I guess it isn't published yet, it's a preprint, but they're from Harvard and University of California, so I'm sure they know what they're doing. All right, would you like to interpret this one for us?
I had a hard time interpreting this in all transparency here, so let me go ahead and pull up the figure legend to see exactly what they intend to relay from this figure.
Sure. While she's doing that, each dot is basically a sample. You have the patients grouped by weeks down below for the weeks since their symptom onset, with 2 weeks being the absolute minimum of any patient in this study, and just over 60 weeks in the last patients. They're color coded, so you know which protein that these assays are done. As Courtney already says, each of these protein assays were done individually. The serum wasn't just ran on all three. which is something you can kind of do. But I guess for specificity on something novel like this that hadn't really been done before or ever tested by the manufacturer, and not knowing what the concentrations would be, I imagine that's why they went with individual assays for each, which I think is an expensive but smart move, makes the study more robust. It's not very cost effective, but I guess it's Harvard and University of California, and they have money. So every time you see a dot that's above this baseline, you can imagine the baseline is your your kind of your null, the false positive sort of rate of what the baseline is, and everything above, and you have this log fold change. Everything above 1.5 or 1, whatever they set the threshold to, is what they're counting as positives. And so what this shows us a little bit here is two things. And again, I'm going to jump back to Courtney and let her read the legend and stuff like that. But it shows us two things. One is it shows us the range of variability of the concentration of these molecules in the serum, so that it's not like, as you can see, that some of them stay a little bit lower. The spike one has like a very consistent profile, whereas the S1 protein is, it's kind of more over the place. But the other thing not shown here yet is a trend line for how these molecules change in their concentration since symptom onset over time. But that's something this kind of graph would be able to show you, to show if it, if it's stable, if it goes down, if it goes up as a trend. Obviously, these are not matched patient samples, so we're not tracking the same patients over time necessarily as much as we'd want to be. A lot of them are just individual samples, although if I remember correctly, there are some matched in here. Is that, if I remember, Courtney, you can correct me if I'm wrong.
Yes, there are some that are matched, and I do believe they go on to expand that in figure 3, which is probably going to be extremely hard to see, but we'll do our best.
Did you want to add anything from the caption that I missed in describing this figure?
You gave me more context than the legend ever could, but there's also more context probably in the supplemental. So word to the wise that are listening, if you have the time, always read supplemental. You might find something beneficial. But I will read the legend just because it may add those context for other people. So quantitative measurements of SARS-CoV-2 spike, S1, and nucleocapsid antigens in plasma among all pandemic era participants during the post-acute phase of SARS-CoV-2 infection. Dashed lines indicate limit of quantification for each antigen, and then the y-axis will refer to the log transform concentration of the antigen in picograms per milliliter. So I do believe you gave us much more context, and that's appreciated.
Yeah, that's what I'm here for. Might as well use those degrees, right? Use them for something. Profiles of SARS-CoV-2 antigen positivity over time with individual pandemic era participants. Want to Rochambeau for it?
Sure.
Your video's not on. They can't watch us do it. We're just going to take your word for it. You're just going to, whatever I do, you're going to say you beat me. That's not fair.
Yeah, they're not going to be able to see that in real time. Anyway, so out of the 159 pandemic era participants, they found that 29 or 18% of them had antigen detected at 1 post-acute time point. 10 or 6.1% had antigen detected at 2 time points, and 1 or 0.63% had antigen detected at all 3, 4, or 5 time points respectively. So just to note here, the majority of the antigen detections, or 84%, did occur before the participants received a vaccine. So I think that is one disclaimer to really keep in mind when you're interpreting something like this. These are individuals that were likely infected by the alpha strain or even something between alpha and Omicron, and the vaccine was not on board. So again, as Wes mentioned earlier, if you've received a vaccine, your chances of developing long COVID were 33% less. So these individuals, had nothing on board to protect them or even attempt to neutralize the virus other than their innate immune systems. So it could be a point that might skew the data. So I would like to see this repeated in a larger study. But again, we run into that limiting factor of, well, we can't find a control group because everybody's had COVID at this point. But what would be interesting would be to compare maybe 3 groups, right? The people who have not been infected, if they're found, those that have been, infected but recover, or those that are still having long COVID symptoms. I think that would be a good way to see this progress in a way that's beneficial for science as a whole, and as well as those suffering from long COVID.
Yeah, I'm also interested how transient the detection was. The fact that only 6% of the people they had matched, only 6% could detect at 2 time points.
Mm-hmm.
So the two things are how fast does it drop off, or do you have to catch it at a let's accept the hypothesis. Okay, let's say this is everything we're detecting here is from active viral persistence of SARS-CoV-2. Let's accept that hypothesis. Then let's say it's not always. Let's say these reservoirs aren't always active. Let's say they go on and off. They're in phases and some sort of equilibrium. Then instead of this being a time strip, do you have to catch it at a certain active state, similar to like tuberculosis, where it can be, it can go into these dormant stages for months and months and months at a time, and then all of a sudden you develop symptoms, 8 to 10 months later. I don't think that fits the LC kind of pathophysiology, but in terms of detection, it might. That like 6.3% is not a fantastic number.
No, it's not. And the other thing to maybe think about, whether or not it's transient or dormant or what have you, they're only testing this every 4 months. So I think, some of this could be missed simply because of that design.
Yes, that's a good point. The 4-month period is enough time to potentially clear a viral persistence, right? We saw with SARS-1 that, the vast majority of patients who had what was not called long COVID at the time, but was, post-viral syndrome from SARS-1, the vast majority of those patients' symptoms recovered after 9 months. So if you're taking a 4-month and an 8-month, there is a non-zero amount of patients who it's not, maybe your test is still just as accurate. It's not about inconsistency. It's just that some of those people have cleared the virus now. So that's also potential. But I guess just what I was thinking, assuming 4 months was the first second time point after the let's say it was a 2-week and a 4-month, hypothetically, for these people, and it was all the same for all of them. I know it's not. I know for each patient it's a slightly different time point. But hypothetically, if it was all the same, you're losing 3% specificity, like a detection ability from your 9.4 you had at the beginning of patients that were positive of the group that had it, in terms of how many people had viral persistence, which that number makes sense with the literature. We'll get back to that again in the discussion. And now we're saying that actually of that 9.4, which we're confident is, legit because we have big numbers, when we break it down to kind of smaller numbers and consistent testing, maybe our ability to detect 9.3 is actually 6.3. We of the 9.4 patients who have the viral persistence, if they were just to come in the clinic on any random day within their post-viral event, we might only catch it. We might miss we miss 33% of it, right? Because that's
right.
So it's an interesting thing that I hadn't really dawned on me until looking at that number.
I definitely think it's a starting point, but there are limitations and some issues, and I hope that if they're able to redo this at a larger scale, or someone else picks it up, that we see a repeat of this, but maybe not the ancestral lineage, something more current.
Yeah. And to fit this kind of transient capture, Paul in the chat brings up the point that many long haulers talk about the disease coming in waves. So maybe it is going into sort of like a non-pathogenic reservoir and then becoming activated and having a more viral persistence phenotype for the physiopathology, pathophysiology. Thanks, Paul. It's a good point. Figure 3. Woo.
This is quite large, but I thought that it was interesting that they added each patient profile. So I don't know if we can pick out a couple and then maybe zoom in if you have that ability on YouTube Live, because
Yeah, I
there
can
are some
zoom in.
interesting ones.
I think one thing I will say is that this is something that, depending on your study, might end up in the supplemental. Um,
It might have a good place for supplemental, but
um,
they did include this as figure 3.
all right, here's what we're gonna do. We're gonna bring this over here, and we're gonna switch to a pre-set up version of the paper that I have.
Perfect.
And then within that paper, we will scroll to the figure, and I'll be able to make that bigger.
And I think this actually does play into the hypothesis of, some of this might be a dormant stage. And there are a handful of patients that kind of, in my opinion, look as if they are in a dormancy stage and then it returns. And not every antigen, but specific ones.
Yeah. All right. I got it nice and big. Any patient we should focus on, you think?
33 interests me.
All right. So we'll go to patient 33. Oh, yeah. That's interesting.
So just for those that are trying to see this really tiny figure, we'll give you the color legend out loud. The S1 is labeled in red, the spike protein is in blue, and then the nucleocapsid is in green. So what's interesting to me, and there's a handful of them, so we can kind of move around if you'd like, but 33, for example, their S1 protein found, or antigen at this point, dipped between weeks 10 and 20 and then ramped back up.
I would probably say this is just a false negative on that testing day.
Potentially. Or is this a dormancy versus reinfection period? Because that's something that they did not track. They did not look at reinfections.
It could be. It could be. With one, if I had a second down data point, I'd be more likely to trust it. When I have these like 4 other high ones, as someone who's worked in a laboratory and done flow cytometry experiments and assays, if a single time point drops and then goes back up to where the expected model would be, more often than not, the assay failed, the beads didn't bind, the antibodies didn't work, they got washed out, the sample, you did a cleaning step and you lost your cells. And that's why you do, and that's why you take the average of these things, right, to compensate for that error. But I don't know. I mean, you're right. It could be like, oh, they cleared entirely from the highest log fold change, and then were reinfected sometime before being retested again.
And not everyone, has the same antigenic response post-infection. No. Some only have S1, some only have the nucleocapsid. So to me, and that's interesting in itself. And I will give you one that had 2 down points, just to play devil advocate here.
Sure.
Patient 13 has 2 down points, and then goes back up, and that's specifically in the spike protein.
Yeah, I mean, different protein this time, but yeah, that could either mean reinfection or what Paul was talking about with the wave, kind of the waveform for the symptoms. It's interesting that I'm going to zoom out just for a sec so I can quickly find one. There wasn't like within the multi-sample group. There's not a great argument for, in my opinion, dropping any particular one from the assay. I mean, obviously, I think the p-values for the S1, if I'm remembering it right, were essentially null, right? So it makes it look like why include S1? But I think you get the values by having the aggregate. And the inconsistency here is strong. I'm going to go to patient 42 really quickly. I'm going to zoom in on patient 42. This, in my opinion, looks like a great case for reinfection at some point after day 35.
Absolutely.
Potentially even with a different strain than the first strain.
And I mean, that brings up a good question that I've kind of, played around with, but never really found an answer. Do you think if we were to have an all-encompassing study that they should look at strain in each individual to know what strain is causing which symptom, or does that matter at this point, in your opinion?
Um, it's an interesting scientifically. I think intellectually, it's an interesting question. Um, I think you can do a little bit of retroactive to get a statistical probability of what strain each patient was based on when they were infected, where they lived, and what strains were the most abundant in that region at the time. Um, I think it'll be impossible to mark it down to a single strain in these um, retrospective kind of studies, where you didn't have, especially when you had these patients who had acute. These patients were recruited saying, "Hey, did you recently have COVID in the last 2 weeks?" How, and getting that, PCRing that sample, I think would be harder, especially when we're talking about that the amount of spike protein we're seeing in the blood is less than 30 picograms per mil. I doubt we're going to be able to find the virus to PCR it. And some patients you will. Everything's a bell curve. Some of them you will. I think realistically, to do a study like that would be very tricky, other than just inferring from where they lived when they were infected and what strains were going around. Paul asks, is there any patient with a clear continuous infection or a classic drop-off of clearing it? They all look quite noisy in aggregate. I mean, you're right. They are very noisy in general. There isn't really a consistent theme, and the baseline zeros aren't zero for most of them, which either implies you're calling those positives, or you're taking your X% as your false positive rate for detection levels. It's interesting. I mean, I don't see anyone that stands out as being. Let me see. I mean, patient 38 doesn't have a lot of time points. But
yeah, that one dropped off.
I just want to. Oh no. Okay, guys, everyone, listen up. They have given every one of these graphs a different y-axis.
No.
They have scaled every patient data to its maximum. So I was trying to interpret two patients just now, looking at how much that went up from the baseline, and I was like, oh wait, actually, this scale starts at a very different number and goes to a different number. It's not by a lot, but when you're talking about log fold changes, 1.2 versus 1.4 is kind of a big deal on these scales. Like patient 12 has like a little bit of a bump, and and one of the proteins at one time point at day 10, and now I'm like, oh wait, actually that's not the same scale as the one before it, where the log fold change goes up to like, I think it's like 2 point something, where the other scaling goes up to 1.
And just a quick thing there, it's 10 weeks. They did weeks rather than days.
Yeah. So as you can see, at week 10, patient 12, this scale goes to 1.2 log fold change, having 0.6 log fold be at the bottom scale. And then patient 11 beside them starts at the same spot, because the green antigen here, the N, which is N, green is N. The N protein has a much lower baseline, it looks like, for the signal ratio. And its scale goes much higher than 1.2. It's hard to see specifically because this text is on top of each other for patient 11, but it almost looks like it could be 1 point. It almost looks like it's. What would you say the top number is for patient 11? Because I'm seeing it as, I know what I think my number is, but I just want to hear what you say.
I'm trying to zoom in, and the more I do that, the blurrier it gets. To be honest.
Chat, what do you think patient 11's top is? Paul says 1.6. That's what I was gonna say. I think the 1 is underneath this 4. I think this is 1. I think this is 1. I think this is 1.2, 1.4, 1.6.
1.6.
Yeah. Good. I mean, it's a preprint, guys. It's a preprint. These are things you can fix in ggplot pretty easily with scaling. Yeah, there isn't really one that stands out as being. But yeah, patient 13, I think that's interesting. We already looked at that one. Patient 14. Patient 14 really shows that lag.
Yeah.
Which is interesting. You know what would be
It's
interesting
later.
data to have, which we don't have, is the same serum test in acute symptomatic SARS-2 infection.
Right. To see, if it ramps up, if it decays, or if it is a delayed response.
Yeah, I'd be keen to know that. I'm sure that'll be the next. Now that they have the assay, I'm sure they're going to do it. It's the next obvious question. All right, I'm back. I'm going to switch back to the slides. We're making good time though. It's only 7:30.
Yeah. Well,
Killing
we're
it.
fast talkers, I guess.
We're killing it. Don't have to put everyone to sleep. All right. Determinants of antigen positivity among pandemic era participants. So they found no strong evidence of an association between age, sex, race, ethnicity, HIV status, or body mass index with SARS-2 antigen positivity at any point between the 3 and 14 months in the post-acute period of infection. Markers of severity in the acute phase of SARS-CoV-2 infection were related to subsequent SARS-CoV-2 antigen positivity. Hospitalized, 2 times more likely to have antigen detected, not hospitalized, but reported the worst overall health during acute phase, had 2.5 times as likely to have antigen detected compared to most benign self-reports. Okay. That's
So, I
interesting.
think it shows promise. There's some issues that we've highlighted a little bit,
Yeah.
but if we could foresee this going to, bedside, essentially, do you have a panel of all 3 proteins that you then test for to determine what the problem might be?
Yeah. And I mean, those are the, it fits with the other group data we have, ignoring, long COVID, but just looking at acute COVID damage, heart damage, vascular damage from just having SARS-2 and let's say clearing it. We know that those things are associated with, most severe symptoms. So the more severe your symptoms are, the more likely you are to get those things. Not that you have a 0% chance of having none of those issues if you had, almost no symptoms, but on general, patients who were hospitalized had more worse outcomes post-virus. From viral damage, so it kind of fits that. You'd imagine that if you had more severe symptoms, it could stick around longer. If your immune system isn't, clearing the acute. If you're 2 weeks out, when we talk about 14 days, that's just it doesn't mean that some people don't take longer than to get out of the acute phase than 14 days before being negative.
Right, and that's the other point of I wanted to bring up regarding the groups that were selected and used for the study, right? We know that HIV does damage the immune system to some degree. So are you basically stacking the deck in the study so you know that you're going to have some sort of response, given that they are less likely to clear it than the average population? I would like to see non-HIV individuals be ran through the same set of studies. And if there's any type of temporal change or overall magnitude in terms of what's being, found or secreted. So maybe, right? It's still preprint. They'll come back and add that. But I think the limiting factor would be, are these biobanks available? So it's just a confound.
Yeah. I mean, the healthy control biobanks from pre-pandemic do exist. They probably could try to tap one of those. I think those kind of data sets are going to become very valuable going forward, and people may not want to waste them, especially since normal healthy controls historically have been the most easy and abundant. You just get the people who work in the lab to give their blood and all their family members and whatnot. But in this case, they're not good pre-pandemic controls anymore. So it's only what you have stored. It'll be interesting. It's gonna be tricky, but I mean, for other diseases, there's gonna be tons. There's biobank data for diabetes. There's biobank data for almost every cancer that is like in the top 5 cancers for that particular group. There's even pediatric brain tumors. There's giant biobanks. So diseases will have tons. Healthy
Right.
controls pre-pandemic is going to get scarce, I think. All right, discussion.
So this is just a summary of the high points. Then we'll go over limitations and then open the floor for any other audience member that has remaining questions. So they found that the persistent symptoms in some of the COVID-19 patients would suggest that a persistent post-infection does occur and can occur, at least in plasma, for up to 14 months post-infection, which might be influenced by the acute infection events. So whether or not you're hospitalized versus treating it at home, et cetera, how severe your infection might have been. And the immunoreactivity-based detection of SARS-CoV-2 in plasma does lack complete specificity with a 2% false positivity. However, that is quite a low number. So my confidence in this being used as a test has not really been affected by that false positivity rate. Even ANAs, right? They shoot positive. That's why you take them over, every 3 months for about a year to determine if someone has an ANA or lupus or other autoimmune disease.
Yeah. It's interesting. All right, so I just thinking back a bit to that point from before. I mean, listen, if you have less than 50 copies of HIV per millimeter, you're basically undetectable in viral standard viral load tests, and assuming you're still on your retroantiviral cocktail therapy, ART therapy. I maybe my information's lacking, but they shouldn't necessarily. Their immune system should be pretty okay. There's less virus, therefore there's less virus infecting their T cells. Therefore, their T cells should be fairly at undetectable levels. I don't think there is. I mean, I'll look at the studies. I don't know, but my understanding was that based on these new retroantivirals we have and the undetectable levels of HIV, that unless something else happened that weakened their immune system that allowed the HIV to get out of control, that they wouldn't, unless something else basically immunocompromised them, like SARS, that it shouldn't have any other impact. But I guess, but then SARS can cause immunodeficiencies. All right. Sorry, it's the first time I thought about this in this kind of circular logic here. Interesting.
That'll be the nerdery after dark discussion.
Yeah, for those who don't know, we do a nerd after dark after our journal clubs on Twitter. If you follow me on Twitter at Wesley Wilson, you can just see what space I'm in, and I'll be in the nerd talk after dark, and you can join us for a more nerdy discussion. Yeah, it's interesting. All right, I'm going to switch back quickly to the chat. We got Paul. You sustain the immune system with HIV. The immune status depends on how early the infection was caught and treated. Yep. And I'm going to switch over to... yeah, I mean, I guess it depends on when they become... You're right, Paul kind of brings up the point is if they were just undetectable for a short period of time, that their T cell ratios might not be back to normal yet.
Sure.
And depending on their age, perhaps, even if they didn't have an active thyroid anymore, it could change some T cell subtypes. All right, I'm just going to switch to Twitter quick to see if anyone's left us any messages on the Twitter box. All right, and then back to here. All right, is there any other take-homes you thought you wanted to kind of discuss about this one, Courtney?
There were 4 more points on the next slide. If you want to read those, we can have a discussion, and then I think we can relatively close this up.
This is the second discussion slide, or the limitations, and what's next slide?
Second discussion.
All right, studies showed varied rates of SARS-CoV-2 persistence influenced by symptomatic severity and study design. Yep, we covered that. B cell immunity evolution suggests potential SARS-CoV-2 persistence. Hospitalized COVID-19 patients have higher rates of persistent SARS-CoV-2 presence. I mean, assuming the hypothesis that that's what we're detecting here. And intermittent antigen detection over time suggests potential variability in antigen production or clearance.
Which I think we kind of went through with the large figure 3.
Yes.
You know, we don't have an idea if they're clearing this, if they're reinfected. It's very open-ended. Does it work? Yes, it's definitely proof of concept. Is it perfect? I don't know.
Yeah. We have another question. I think it's going to wait for. We have a couple questions. David's joined. We got Martha. I got John. Hey, John. Welcome. Hey, Martha.
Hi, everybody.
Thanks for tuning in. We'll move on to this next slide, and then I'm going to answer some of those questions for the limitations. So limitations and what's next. Study limitations include convenient sampling. That's true. So these were, for a lot of reasons, University of California, a lot of these patients are in California. Ancestral strain infections is another limitation. Lack of assessment for asymptomatic reinfection, also a great point. We kind of talked about that a little bit in some of the data, with some of that just reinfection points that we're testing here, and we don't know what the baseline acute looks like. So if we had a reinfection on sampling, even if it was, let's say it wasn't 2 weeks old again, let's say it was like active, we don't have a baseline for these markers in the blood. Urgent questions arise about causal relationship between persistent SARS-CoV-2 and post-acute symptoms. Yes, very true. Very good point. I think that's why a lot of people are watching today, because they are really interested in that.
Mm-hmm.
John, thank you. I'm going to read your comment out after. Ongoing studies aim to understand and address the implications of persistent SARS-CoV-2. And I think, that's, for me, that last point is where this test is very useful. Is studying persistence more. Now that we have something that can kind of pseudo detect it, now we can actually ask more questions about those relationships and persistence.
Absolutely.
John says it's so different here on YouTube. Great presentation. I love visual learning. I like visual learning too, John. I like having the graphs. I like having the figures. I'm a visual learner. I think that's maybe not even a real thing, but I still say it, and I think it's true. Being able to have these figures up here. Martha asks, is there any test currently that can tell if someone's ever had SARS-2?
Well,
Courtney?
the only one that I know of is the nucleocapsid test, right? So if you have the nucleocapsid, that's unique to specifically SARS-CoV-2. It has nothing to do with the vaccines, but there is a time limit, to the best of my knowledge, as to when that test can be taken. So it's usually a 6-month limit, right? 6 months past your infection, that should be detected, which makes sense given this particular graph here with the Samoa. In regards to the expense, Martha, I'm not sure, but I can do a little digging on that to see what that test would cost. But if you are able to see past the closed captions, the lower panel C does look at the N antigen, and you can see that you have a higher amount detected between month 3 and 6. So going beyond that, the sensitivity of the test currently available is probably not as high as a Samoa assay. So your chances of detecting that beyond month 6, even if you had COVID, would be slim.
Yeah, there's so in terms of cost, the test itself to manufacture and do is not that expensive, but individual vendors and clinics might upsell it quite a bit, Martha. So I don't know how much it would cost per se. If you're in Canada and there was a biological reason to give a treatment or not give a treatment based on your previous infection, the test would probably be covered since it would be deemed medically necessary, so it wouldn't cost you anything. But if you're just curious, you probably have to pay out of pocket in Canada as well. There is another kind of approach to this, and it has 2 limitations. So Courtney brought up the great point that, just looking at antibodies, do you have antibodies to SARS in your blood? would be true if you got the vaccine and you developed antibodies towards the vaccine, right? So it's not a fantastic assay for these things. However, that being said, you can do an antibody assay towards non-spike related proteins that are SARS-2 viral, and the idea then would be that they should only be developed by your immune system interacting with the virus and not from the spike protein that has been generated by the vaccines right now, which are, okay, that's a lie. The Johnson & Johnson vaccine would be an exclusion to this. It wouldn't, if you had that one, this wouldn't work entirely. And the AstraZeneca vaccine, I think, also may fail this test. But the Pfizer and the Moderna and the Novavax vaccines, you should be able to tell the difference in those antibodies from an actual infection versus just induced by the vaccine, assuming you actually seroconverted in the first place from being infected. Did that make sense? Did I explain that properly?
Crystal for me. Anybody in the chat have questions after that?
All right, I'm going to go back up to make sure I didn't miss anything of Paul's while we were going through the discussion.
Yeah, I was trying to keep up, but there's a little bit of a lag on my end, given that I'm not running said YouTube channel.
That's true. My texts come in faster, which is pretty great. All right. So before we kind of end, John wants to explain seroconversion. Sure. Seroconversion is basically, so you have your immune system is full of tons of cells. You got dendritic cells, you got B cells, you got T cells, you got macrophages. You have all these things. The cells that are most important for clearing out SARS-2 infections are your T cells and your B cells. B cells, when they get activated and they're shown the virus and what pieces of the virus, they will release antibodies, and those antibodies can then bind to cells that are also infected and mark them for destruction and clearance. If your B cells get activated and your B cells release these antibodies into your serum, into your blood, that can bind to these infected cells and to these infected cell proteins, that's called seroconversion. Your serum now has positive for the antibodies that your B cells are releasing. So for children, for example, most children who get SARS-2 don't seroconvert. They don't actually end up developing antibodies to SARS-CoV-2, at least in all the studies looking at alpha up until delta before the vaccine rollouts. They just weren't. So most of their viral clearance was due to their T cells, a different immune cell, which is really good at killing things that aren't supposed to be there, like funguses, bacteria, viruses, things when they're in there, not even cancers. Things that aren't supposed to be there that look different, T cells will just go straight up and murder them. So that's how children usually clear the virus. Again, some children do seroconvert. It's just rare. Most adults have been seroconverting, healthy adults with healthy immune systems. And then you have situations where people don't have healthy immune systems, immunocompromised patients, cancer patients, AIDS patients, even diabetics are technically in that classification of immunocompromised. And Martha, that's correct. We don't necessarily know who seroconverts unless you take a test. So for the what next, I think I'm really excited for a test like this to be used the two things I'm excited for. One is to study viral persistence as just a general theme from SARS-2, and how that's detectable, and then scoring, because how many people, like from this, we're basically saying 9% of people, if we give this thing 100% accuracy, but 9% of people have some sort of viral persistence for at least 2 weeks, right? Which is consistent with the other literature that has kind of speculated around this. So that number doesn't surprise me. But studying that 9% now having a screening tool, an accurate screening tool to say definitively, not just like, of this 1 million patients I enrolled in my study, I can assume 9,000 of them have persistence, and I'm going to, and so I'm going to take it in an aggregate and know my percentages and deconvolute my data. You can say, actually, I'm going to screen, a million patients, and then I'm going to take 9,000 that I know have viral persistence, and then study that group and get way more deep into the question, get way more, instead of just guessing. We now have an assay that can help us really figure out what's connected to what symptoms are connected to what percentage of viral persistence patients are asymptomatic, that they have no symptoms, and correlating that to cardiac outcomes. We know from SARS-2 acute infections, cardiac damage is really high. Viral persistence, is this also a risk factor? Does this continue on with the cardiac risk? I think that's going to be a really interesting, just studying this phenomenon in a way we just couldn't before. So like just having this as a tool for other people to do other studies, I think is really important. And then clinically, I think where this is going to be really useful is for clinical trials around long COVID, where the hypothesis is viral persistence, right? So, we talk about people within the long COVID community, lots of clinical trials, lots of different things, that people are trying. Some things work for some people, some things work for other people. And, the reality is that this is, right now, very much more like a syndrome where like everybody's put into this one bucket. I'm going to bring us back to our 3 because we're not really showing any slides right now. Everyone's in this one bucket. So, but the bucket is actually probably lots of smaller buckets. And so the fact that one medication works for someone, doesn't work for somebody else, isn't necessarily that medication's bad, but because the underlying mechanism between those two people is probably very different. And so if you can use this assay to kind of screen the patients that enter your clinical trial, let's say your hypothesis is that, these symptoms are all caused by viral persistence, I'm going to treat it with a cocktail for retroentry vials that I think will be good. These antivirals will be good for SARS-CoV-2. You want to make sure in giving your cohort of patients the best opportunity for success to know they have viral persistence. So if you were just to recruit, 1,000 long COVID patients, and let's say, I'm just making this number up, not based on literature, 30% of them had viral persistence, and then your drug only worked in 15% of the patients, your drug might be like, oh, this isn't effective. 50% is not much greater than background and placebo. I'm going to move on to something else. But if you knew that only 30% of your patients had viral persistence and you had 50% response, now your treatment works 50% of the time. And so if you could recruit instead of 30% of the patient population you're trying to treat, but in 100%, then you're making it easier for us to develop new treatments for long COVID based on this particular hypothesis of mechanism of pathophysiology. Of course, there are other, other hypotheses for other mechanisms. And so for me, that's a big clinical takeaway. And previously that I mentioned with the other study design stuff, academic kind of understanding persistence better. So those are my takeaways. I'm going to go to Courtney if she has anything extra to add, but her takeaways from the paper.
I think again, it's a good, springboard for somebody to start and continue with. But, figure 3, as large as that might be, it was interesting to see individual responsiveness to spike versus S1 versus N. So if we could personalize it to a level that, we can find something that works for these individuals based on what antigen is causing persistence within them, it might be a good thing.
Do you think, so this brings up a good question here. Do you think this is a difference in simply individual biology, that the biological differences that separate every individual, that this is an artifact of that, of what's being presented and is available in the serum? Or do you think that these protein abundances are actually, the different proteins that are detectable are actually connected to different symptoms? Because I wasn't interpreting it that way, but maybe
it's too early to tell, I think. But
Okay.
I would be more concerned if the nucleocapsid is, like we've mentioned in the PEM paper, which I don't think you were around for that, is, causing the persistent damage. What they're saying in the zombie fragments paper is that additional insult or stress can actually cause these fragments to basically reassemble, pull the transformer in your body, and wreak havoc again.
Right.
So if we knew individual subcomponents, be it the S spike protein or the nucleocapsid are driving that reassembly,
Mm-hmm.
it's a minute thing and maybe it's not present in everyone, but knowing that, in the future, I think could only be a benefit.
Yeah, I see what you're saying. I see what you're saying. I think, yeah. I mean, potentially, who knows what the future could do. I think my brain went to like the DC feedback loops where it's
Sure.
just constantly reactivating, presenting antigen and reactivating the immune system and keeping the basically your immune system. It's like having chronic inflammation, but at a T cell, B cell level, and in terms of activation and proliferation, not just like cytokine and interferon. Um, and in my mind, the treatment for that would be agnostic to which of these proteins was causing the feedback loop.
Right.
But I would be interested for myself to jump into the literature and just see the S1 to N ratios in patients with acute, and how consistent are those ratios? Because I guess I sort of thought that they'd be fairly consistent within a strain, within a single strain. Let's say we
Mm-hmm.
took the Delta strain. My assumption would have been that those ratios of protein production would be fairly consistent. That it wouldn't make too much sense for the viral genome to have, copy number variations to an extreme that, that we'd be pulling out that we would see a super noisy signal.
Mm-hmm.
I don't know, just my thought within a strain.
Well, we can certainly peruse the interwebs and see what literature is out there during tea time or nerds after dark or whatever we want to consider this.
Yes, definitely. We'll be heading to the Nerds After Dark after this. Paul says that he fears this isn't sensitive enough studied intake since 9.6 across 3 to 6 tenths of patients over nearly a year. Any visual point is too low. I mean, I think if you get, if your criteria, if you assume that it's like cyclical and that it goes in cycles, and it's not all just reinfections, then any one positive would be entry criteria in that sense. But the 9.6 matches other studies that have predicted and tried to scale what the viral persistence would be from an infection group. So I mean, it's at random. Again, this is not a very random population. It's people who live in California, but which means they have access to a certain amount of healthcare and they have access to a certain amount of vaccines. I think individual. Again, that's why I think you need to have all three of these markers individually. None of these markers are fantastically consistent. And I think you need the three for the aggregate. Even the non-statistically significant one, the S1 antigen. Because it's only with all three that you get statistical significance at 10 to 14 months. Yeah, Paul, I agree, 100%. I agree with you. I'd love to see what this looks like with acute patients. 100% agree. All right, I think we're going to wrap it up. We made amazing time. I think I like this format in the future. I'm not necessarily saying this YouTube format, but I think this format of summarizing the slides and not reading the paper directly word for word worked really good. I'll switch back
Yeah,
to this.
I mean, I'm for doing this again.
Yeah.
And then maybe only doing a narrated version of this is how you critically think and read papers maybe once every, I don't know, 3 or 4 journal clubs, but we will confer with Cindy. And for those of you who joined a little later, Cindy was unable to attend tonight. She is dealing with a barn emergency and delivering an animal as we
Yep.
speak. So waiting anxiously on the update for the overall health of the baby and mom. So we shall see.
Our resident veterinarian. So yeah, if you want to find more of our Journal Club spaces, we do have the Pop-Up Journal Club Twitter account that Courtney kind of runs. This is Courtney's baby. If it looks like I'm hosting, it's just because I have OBS software on my computer, and that's the only reason. This is Courtney's brainchild. So all credit to Courtney. You can follow that. You can follow her. You can follow me. Only follow this YouTube channel if you want to stay up to date on the cancer live streams. We are on the Tumor Talk channel today because we didn't have time to set up a separate YouTube account. But follow us on Twitter. You like and subscribe to this page if you want to follow the tumor stuff. You can buy a shirt and support cancer research. I'm wearing one. It's a snazzy "We're in this together" shirt that I designed.
I thought you wore that because it matched our slides, but I do appreciate that it's for cancer.
Thank you. Proceeds go to support cancer research. Cancer Research Institute. No, actually, I think it's actually the American Cancer Society now. Every year I switch who the money gets donated to. Yeah.
Do you have a link for said merch?
I do. I believe. Actually, I should double check this because I don't want to send people the wrong way. Right. Yes, it is store.tumortalk.show. Store.tumortalk.show. Store.com. Store.tumortalkshow.com. And you can buy the shirt. You can buy a mug. I even have a sticker I made on site at a conference I was presenting at because someone liked one of my graphs. And they're like, oh, I want that figure as a sticker. And it's there as well. All right, guys. We'll catch you later. Join us for our Nerd After Dark talk if you want on Twitter. And I will play us out with some music from Sandra Boza, who's currently on tour in Ontario for her new album. And I don't have any links for that, but maybe I'll post it in the comments after. Take care, everyone. Enjoy your weekend for those who it's a Friday night for. And we'll talk to you again soon.
Thanks, everyone.
Tell me the truth, babe. Do I still make your blood boil? Tell me the truth, babe. Would you still ring around the world for me now? Tell me the truth, babe. When's the last time that you screamed my name?